I think we'll get started. So thank you everyone for joining us today. My name is Lauren Dibson and I am representing the NDSU Department of Public Health seminar series today. I have the honor of introducing Dr. Strand, who will be presenting Healthy Individuals in Sick Populations. What is going on? So Dr. Strand is a professor in the School of Pharmacy and Department of Public Health at NDSU. Dr. Strand has devoted his career to improve population health through the application of epidemiology and implementation science. He works closely with local public health in North Dakota and is committed to helping students prepare to work in the public health field. If there is time at the end, Dr. Strand will answer questions after the webinar. Please type these questions into our chat feature. Otherwise, we also will try to maybe informally allow for people to ask questions virtually as well. Dr. Strand, thank you so much. I will turn it over to you.
Hello, everyone. Thanks for joining today's seminar. And I hope I can answer the question I've posed today in the time we have together. It's an important topic for all of us. And I'd like to also point out this is a bit of an expansion on a talk I gave last Friday at the Interprofessional Collaboration Conference, in case anyone attended that. So the America's Health Rankings every year ranks all the states in the country based on clinical care, health outcomes, health behaviors, physical environment, and social and economic factors. And I'm sorry to say that North Dakota went from being the #1 healthiest state in the country in 1990 and has seen a steady decline in national ranking up to the present, ranked at 19th. Now, I'm a native North Dakotan and I'm proud of my state and I love my state, but I still hope to be able to be, objective and critical in trying to help our state reclaim that kind of position as we seek to serve the people of our state who desire health and well-being. We have to do better, and I'm going to ask you today to have a thick skin. This is no critique of any individual or any aspect of our health system, but it's a call to all people who are devoted to health in North Dakota to see if together we can reclaim ourselves as the healthiest state in the nation. For starters, I'd like to define population health. Population health is basically where people live their lives, live, work, and play. You've heard these definitions. Because let's face it, most people spend 5,834 of their waking hours living their normal lives in the population of which they are a part, and 6 hours a year in healthcare systems. So it's unrealistic to think that our medical system could somehow improve population health when they only get that little bit of a time interacting with patients. So we need to think from a new perspective, and that perspective is population health. Population health is the health outcomes of groups of individuals, so think subpopulations, including the variable distribution of such health outcomes within the group. Population health helps us to assess why some populations are healthier than others, the mechanisms through which these factors move through populations, and how to improve these things at the population level. For example, 10% of North Dakotans have diabetes, but it's not as if diabetes is equally distributed among all people in North Dakota, but rather there are subpopulations with higher rates and lower rates. So in order to move the needle on population health in North Dakota, just improving individual level patient care would be a necessary but insufficient factor. We also need to consider the groups who have shared risks and shared health outcomes, and then use group approaches to improve their health. So what do I mean by healthy individuals in sick populations? This is a picture from the Rib Fest, and I'm just using it as an example of healthy individuals living in sick populations. So how do I define these terms? Well, first, healthy individuals. You probably are living a healthy life yourself, and many people around you are too. You probably are not devastated by any chronic disease, and you have good social connections, living the life you choose with stable employment, health insurance, access to good health care, and adequate housing. That's a definition of a healthy individual. And you see many people around you who look like that. But with so many healthy individuals in North Dakota, how could we claim that we have sick populations? While most of us find our health to be good and our healthcare provided to be effective, we have many people in our state who don't experience that. So when I say sick populations, I'm talking about subpopulations within the state who have lower life expectancy, higher burden of disease. They're made vulnerable by the systems in which they live, resulting in inequities. For example, to compare once again, we know smokers and obese persons and those who eat poorly, who all in all are quite healthy. They're living a good life. And in the moment, they would be a healthy individual. However, these risk factors don't operate on the order of days or even months, but rather years and perhaps decades. And so we don't see the association that what appears to be a healthy individual could potentially be a part of, either presently or in the future, a sick population. This is the paradox where the population that we perceive to have mostly healthy individuals is actually not a healthy population. Now, this is confusing to some, but bear with me. I hope today I can help make that clearer. So a sick population then is those characteristics of shortened life expectancy, certain challenges to accessing resources such as places to exercise or good food, fresh fruits and vegetables, living with high stress, unstable housing, limited access to healthy recreational activities, and others. Okay, so given that introduction to population health and defining my terms, what are North Dakota's most pressing health problems? And I hasten to add that North Dakota is better than many states in the country. I mean, after all, we are 19th in many areas, such as high school graduation rates, air and water quality, public health funding per person, and others. However, there are areas where we could do better, and I'll get to those in a moment. But first, let's consider again a US phenomenon of declining life expectancy. You'll notice from the 50s up into even the 90s, there was a steady extension of life expectancy on the national level. However, starting in 2010, considered phase 5, you'll notice that life expectancy stopped increasing. And to our great surprise, from 2019 to the present, has experienced a remarkable decline of over 2 years of life expectancy reduction. And this has also been found in our own state of North Dakota. Now, I'd like to consider life expectancy at the county level in North Dakota, because life expectancy is a sensitive indicator to population health because it reflects a long period of time and a whole array of factors. Now, North Dakota overall is a life expectancy of 80 years, which is higher than the national average of 77.3. But it begs the question, who is experiencing this longer life expectancy in North Dakota and who is not? This county map shows from the red color would be individuals with the lowest life expectancy. So Sioux County on the bottom, 68 years. To the darkest blue counties, you'll see are the ones that have life expectancy of 82 years. And you see that they're typically oriented in pockets. Now, what I did is I took the upper 5 counties for life expectancy and compared them to the lower 5 counties for life expectancy. And this is what we learned. So the 5 counties with the highest life expectancy, and they're shown there. If you're familiar with the geography, you'll notice some of these communities: Beach, Center, McCluskey, Lemoore, Findlay, and Bismarck, with a mean life expectancy in those counties of 82.7 years. On the other hand, the lowest counties by life expectancy are shown as well. And that's with an average life expectancy of 73.4 years. And you'll notice in the comments column that unfortunately, those 5 counties all represent counties who have extensive overlap with our tribal communities. This results in a situation where the county with the highest life expectancy, Golden Valley, to that with the lowest, Sioux County, has a 15.9-year difference in life expectancy. And even if you take the average of the top 5 to the bottom 5, you still end up with a 9.3-year difference in life expectancy. Something is not right. So if we take that same information and plot it in this figure, dividing life expectancy by quartiles, we see the dark blue now representing those communities that have the lowest life expectancies, circled in red, and then the lightest blue, those counties and communities that have the highest life expectancy, circled in green. This gives us a clue as to where we should focus our attention to identify the causes of lower life expectancy, which I'll get to in a moment, and hopefully provide programming to help them. Now, what can explain life expectancy, higher or lower life expectancies? There's 2 ways to explain it. First is that many people die young, and this would be typically due to acute incidences in the first year of life. The other explanation would be that many people die earlier than expected at all ages, and that's typically due to a chronic accumulation of unhealthy factors. Now, bear in mind, this is a different question from how to explain how an individual person died prematurely. For example, if an individual dies of an MI at age 67, the explanation of their individual low life expectancy is that their life was cut short by 13 years due to a heart attack. But this heart attack didn't just happen. It was the result of many years of accrual of poor health. And if a county has low life expectancy, it reflects a lifetime accumulation of health risks and health problems across the population, reflecting a situation at a community or population level. So I don't want to accept that that person just had bad luck and the misfortune of an early death due to MI, which may have been true for that individual. But on a population level, I want to know why some people in counties are dying earlier due to ischemic heart disease than in others. To illustrate the point, this is a figure showing the proportion of individuals at each age unit who in South Dakota who died at that age, comparing American Indian and white persons. If you look first at the yellow bars, you'll see a fair number, almost 8.8% of white children die in the first year of life. But then after that, mortality is very low up until your 50s and 60s, showing a normal distribution hovering around age 80. On the other hand, American Indian populations are subject to both of the explanations for low life expectancy. First, many people die young. 5% of American Indian children die in the first year of life. And then you'll also notice that at every age unit, the bar is shifted significantly to the left by anywhere from 8 to 18 years, so that the number of persons who live to the age of 88 becomes a small proportion. This is a problem. Now I'd like to ask you to consider for a moment. So now we looked at some definitions. Now let's step back and ask some questions at a population level about North Dakota. Now this is a quiz question, so I'll just ask you to answer it sort of off the top of your head. What is the number one cause of mortality in North Dakota? If you answered heart disease, you are correct. And if you want to see the whole list, here's the top 10 causes of mortality in North Dakota: heart disease, cancer, Alzheimer's, respiratory disease, accidents, etc. So that's what causes people to die. Now, what is the number one health problem if you actually combine morbidity, that is living with the disease for a long period of time, not only having that disease take your life or shorten your life, what would you consider to be the number one health problem? Well, it's still ischemic heart disease. So this is a significant issue for consideration. And here's the ranking: ischemic heart disease, lung cancer, COPD, diabetes, low back pain, Alzheimer's, and opioid use disorder. And this is measured as disability adjusted life years. So now let's consider, what are the causes of these health problems? So if this is what it is that's causing our state to have a compromised population health, what is causing these things? So just take a look at that list and think about that. If we were in person, I'd have you holler out the causes, and I'm sure you have lots of things in your mind. But here's what some of those causes are. So now I'd like to ask you, what is the number one risk factor as a contributor to morbidity and mortality? Which of these would you choose? Again, this is just a conversation starter question. If you answered tobacco use, you would be correct. And here's the list of the top 10 risk factors. So tobacco use, obesity, dietary risk, alcohol and drug use, a host of chronic disease risk factors, blood sugar, blood pressure, cholesterol, occupational risks, and then low physical activity. If we combine all the information in the previous slides, we end up with this, on the one hand, complicated sort of image, but on the other hand, if you just pause for a moment and take a peek, you start to see the same risk factors we just looked at contribute on the right to those 7 health outcomes that are the contributors to the greatest burden of disease. And you'll notice that many of the risk factors are contributing to many of the health outcomes. And likewise, many of these most pressing health outcomes have multiple contributing risk factors. So it isn't possible to do a one-for-one, stop this risk factor, you'll stop this negative health outcome. It requires a holistic approach to population health. So let's look at these risk factors for a moment. So tobacco use, we ranked 29th in the country with 15% tobacco users. E-cigarettes were 36th, so that's a problem with our youth. This all took off in the 1960s, and we are now still paying the price for that. How about obesity? North Dakota is ranked 32nd with 35.2% of our adults being obese. Dietary risks, we are 35th for availability of fruits and vegetables. We have food deserts across many of our rural communities. Sugar sweetened beverages and junk food really took off in the 1970s, and then obesity followed in the 80s and diabetes in the 90s. So these are long-term generational changes that have contributed to our compromised population health. Alcohol and drug use, unfortunately, North Dakota is the second highest binge drinking state at 21%. We've seen increased drug deaths as well. In these others, there's a cluster of, chronic disease risk factors, blood sugar, blood pressure, and those are associated with the prior behaviors, obesity, tobacco use, and dietary risks. And then other topics, occupational risks. I learned last week that North Dakota has the highest occupational fatality rate in the country, and that doesn't even include agricultural injuries because those are private. And so there's something about workforce safety or workplace safety that needs to be addressed. Other topics that aren't in this list would include mental health and associated issues that are also besetting our population. Now, those are the risk factors, the health outcomes that contribute to them. I try to propose that they represent a kind of holistic kind of cluster of issues to address. But we also have to think about population health by virtue of populations who are made vulnerable by the systems. And these are the four that we believe North Dakota has particular vulnerability that needs to be addressed. So first is our aging population, which represents 15.7% of our population. Our rural populations face many of the issues on the previous slide, and they represent 39.4% of our population. Our youth, are also made vulnerable by some of these issues. And then also our American Indian populations, as shown by the lower life expectancy in the 5 counties, which are occupied by the Indians who have been forced to those lands by virtue of policy over the last 200 years. And they represent 5.6% of our population. So then we now try to define what are some of the main health challenges in North Dakota, who are the persons most vulnerable to them. And now I'd like to move to a population health approach to improving health among these populations made vulnerable. So now I'd like to sort of combine the risk factors. We saw a cluster take shape, the health outcomes that result from that, which contributes to both lower life expectancy as well as lower quality of life throughout different eras of one's lifetime. And then we looked at those populations, 4 in particular, that are distinctly vulnerable to those conditions. And we also looked earlier at the fact that there's some geographic population level issues that are in play that need to be considered. So now I'd like to try and tie those together with a population health to improve health among North Dakota's populations made vulnerable. So here's a combination, basically bringing those images together that I had just shown you. So the left slide shows those risk factors that are the top 10 risk factors in our state contributing to compromised health. The right side, those health outcomes are the 7 leading burden of disease health problems in our state. And if you were to combine those together, and again, if we were together, we could use a whiteboard and start to put these into groups. I hope you would agree that these together lead to this kind of a picture with 5, what I'm calling high priority focus areas. So first is obesity. Obesity is a reflection of dietary issues, lack of availability of fresh fruits and vegetables, easy access to low caloric or high caloric and low value foods. Obviously, those chronic diseases are a function of obesity challenges. And I do want to hasten to add, I have no desire or intention in this presentation to in any way imply that individuals who suffer from obesity or substance misuse issues is that there's any shame or any stigma to be associated, but rather I'm hoping to make a case that they are themselves victims of policy and population level issues that make it harder for them to manage these risk factors that are presented. So please, I hope I haven't, I don't want to be misunderstood there, because I understand that nobody's, trying to have these various risk factors. So then obesity also then results in ischemic heart disease, diabetes, and low back pain. So you see the association there. So I consider obesity to be a high priority focus area for population health. The second is substance misuse. Obviously, tobacco use is the leading. Alcohol and drug use is number 4. Occupational risks contribute to substance misuse because of just the work environment and the stresses and even the pain that can be associated with those types of work. And that results in lung cancer, diabetes, COPD. So you'll see this is the kind of clustering I'm trying to do now to explain how I generated these 5 high priority focus areas. The third is mental health, and that's not really present in the risk factors directly. However, tobacco use is oftentimes a way of coping with stress and mental health issues. Alcohol and drugs, of course, are very much associated with that, as well as occupational risks. And so mental health issues in low physical activity or lack of access to healthy outdoor environments can also contribute to mental health issues. And that then can also contribute to opioid use disorder or other such things. And you can imagine how the mental health issues are, those groups who are made vulnerable by social factors that I referred to, youth, tribal community members, and rural persons might be especially affected by those mental health challenges. Poverty, and again, you don't see poverty in this list of risk factors, but poverty is higher among, tobacco use is higher among poor persons. Obesity is higher among persons living with low income. Dietary risks or lack of availability to fresh fruits and vegetables. Occupational risks are associated with poverty and low physical activity as well, resulting in low back pain and inability to work. And so then therefore it's sort of a downward spiral of poverty. And then finally, health system deficiencies. Again, that's not described here, but you can see that, if high blood sugar, blood pressure, cholesterol are well managed, then we wouldn't end up with ischemic heart disease and diabetes. But if they're ignored for extended periods of time, then these high prevalence risk factors will result in those negative health outcomes. So this is how I came up with the 5th health system deficiencies. And I'd like to think about it from a population health perspective. Think about this for a moment. Let's imagine that we were able to double the number of clinics and the number of providers of different levels in our state. How do you think that would impact the life expectancy of those counties? And would it actually address the 5 high priority focus areas, especially these first 4 here? Unless those clinics were connected closely to the communities, such as their schools, the Department of Health and Human Services branch, the local public health unit, their local pharmacy, the local grocery store, their local long-term care facility, the police department. Unless those healthcare systems are connected to all those community partners, it's unlikely that they would make a major contribution to addressing those first 4 high priority focus areas. And also, if we could have those providers who are added to the communities implementing programs in the community, sitting on the county commission, focusing on on prevention work along the lines of these risk factors, it could have an impact. But I think you can see that this needs an all hands on deck, all stakeholders at the table approach if we want to address these high priority focus areas. So what do we do? My suggestion is focus our attention on the 5 high priority focus areas using a strategic plan. So let's talk a little bit first about these high priority focus areas, and then I'll propose the strategic plan. So let's talk about obesity. What could we do about obesity? Well, first, reducing barriers to being physically active. Those are physical barriers, policy barriers, and perceptual barriers. Taxing food products that have no nutritional value, such as sugar-sweetened beverages, candy, junk food. My sons recently traveled to Holland for a wedding, and they were tickled to learn that in Holland, sugar-sweetened cereals have to be shelved with candy. They also took note that it was very hard for them to find a place to park their rental car in downtown Amsterdam because the city is decidedly bicycle biased. So everybody rides bikes, and there's more racks for parking your bike than there are for parking cars. These are some radical initiatives. And I asked, so what did you notice about the general body mass? And they were struck by how fewer individuals they saw who had excess body mass. So it does have an impact. A third area would be to ensure fresh fruits and vegetables are available, affordable, and attractive in all communities and in all settings. And there's a lot of ways we could approach that. But I also want to focus on successes, because in North Dakota, we've had a lot of success, and many people on this call have contributed and worked hard to address population health issues in our state. A few examples here. First is obesity from 2016 to 2020 declined by 5.3% to 10.5%. So there is an opportunity here, and let's hope we can hold on to that. On the other hand, I'd like to point out that breastfeeding initiation rates in the US are lowest among American Indians, and North Dakota American Indians have the very lowest breastfeeding initiation rates in the country. So this ties together some of the factors that we're looking at here, including how to better support our tribal communities. So that's obesity. The second, substance misuse or behavioral health issues. Some of the approaches might include regulation on alcohol and tobacco in lines with international best practices, including labeling, for example. Many countries, a packet of cigarettes, it's white in color with a picture of a person who's suffering from oral cancer or something, and that's by law. Similarly, alcohol has to be labeled as harmful to health. So these are just a few of the many best practices that could be considered, including changing social norms toward alcohol and tobacco misuse. But there are successes as well. The Parents Lead program with the Department of Health has done a great job of helping to encourage parents to talk with your teenagers about drug and alcohol and tobacco use. Don't just pretend that it's a taboo subject with our young people, but take the leadership with them. And then also the SOAR funding for opioid safety has also been a significant contributor. The third high priority focus area is mental health. Loneliness in our rural communities and among our elderly, perhaps the use of community health workers to provide services and programming to address these issues. When community health workers are authorized in our state and reimbursed, that'll be an opportunity for us. Addressing healthy recreational opportunities in rural communities could also help with mental health issues. And then incentivizing people to pursue work in the mental health field would be another good one, to increase the workforce committed to that. But there also have been successes with many communities really making personal sacrifice to support and sustain senior centers and, good assisted living facilities that are able to then address some of these mental health issues, for those elderly folks. But for youth and all, there's probably more opportunity for us waiting out there. And then the fourth high priority area is that of poverty. And obviously this touches so many areas, but a few things to consider would be a universal health coverage to prevent financial devastation as a result of a health crisis. Minimum income support includes a lot of things such as minimum wage laws, unemployment benefits, child tax credits, temporary assistance for needy families, disability payments. If people can avoid dropping below a minimum, income level, so many health issues that then get avoided can be addressed. Low-income housing resources being made available, really important. Early childhood education and supporting that. And I'm really happy to see our governor focusing on supporting early childhood education with more political will. And as we know, poverty is a source of tremendous stress that contributes to lots of health problems themselves. Whereas if we can address underlying poverty issues, they're a safeguard against stressors. However, I'd like to point out some success as well. We did see declining poverty rates even prior to COVID. In North Dakota, we have the highest labor force participation in the country, along with ample job opportunities. Now we need to make sure that those jobs are safe, that those jobs are paying a minimum wage, and that those jobs come with basic benefits, health insurance and such. The fifth high priority area that I'm focusing on is deficiencies in our healthcare system. And I'd like to propose that the Department of Health and Human Services should be seen as the hub of health in North Dakota, with the gravitas to bring all stakeholders together, the healthcare systems and all the different players who are related to the health of our people in our state, in our population. We could consider ways to expand provider types. We've seen pharmacists with increased privileges in community pharmacies. It's made a huge impact on community health. And now community health workers could also have certain provider, or at least provider is probably the wrong word, but privileges, I guess, just to be able to contribute to improving population health so that everyone's operating at the top of their licensure and all the needs are being met with appropriate levels of expertise. More cross-sector referrals between, say, human services, clinical care, other sectors, local public health department. So smoothing that pathway. And I know that's been a real priority in the last 10 years, and much progress has been made. And then I'd also like to propose ways for the Indian Health Service and the tribal health councils who are serving the needs of the tribal communities to be better interrelated and integrated with other health systems in order to reduce the inequities and potentially address these many factors that have contributed to lower life expectancy in those tribal communities. One of the successes in the area of healthcare systems is that the uninsurance rate was significantly reduced through Medicaid expansion. So kudos to North Dakota for having been an early and an aggressive Medicaid expansion state, and we've seen the benefit of that. Now, how do we address these 5 high priority focus areas? I'd like to propose that we have a strategic plan for a healthy North Dakota that looks something like this. First, we would have a health in all policies approach to the decisions that are made, both at political level decisions, as well as the local community level decisions, and that these are driven by data. So it would require increasing the informatics capacity of our state agencies and their ability to get data that's needed so we can make decisions that are in the best interest of the health of all. A second feature of a strategic plan would be to expand statewide public health expertise and leadership capacity. So I know that Essentia and Sanford Health are examples where they're increasing the number of persons in their system who are population health experts. And so there's clearly, a priority focus there. And now we need to get those connected with, say, local public health or Department of Human Services in a way that says, how do we improve population health for the whole state? And then a third area would be to enhance cross-sector collaboration and integration, of all those various partners. This strategic plan actually came as a result of Governor Burgum's desire to say, we want to see North Dakota resume our position as the healthiest state in the country. And he wants to see revision and reform and progress in our state in order to accomplish that. Now, here's a way of looking at this back to the populations made vulnerable by our systems. Here's a way of looking at that. Our older adults, and then on the right are the 5 high priority areas. Obesity, mental health, and poverty are a factor with that 15% of our population. Among rural populations, obesity, substance misuse, mental health, poverty, and healthcare deficiencies are factors. Now, please understand, I was raised in rural North Dakota, and as I've said, I love my state and I love the quality of life for many in our rural communities, but we need to see that experienced by more and more of the people in those communities with resources that are needed to address those needs. The same, 5 high priority areas are definitely issues in our tribal communities, which make up 5%, 6% of our population. And then finally, youth are particularly vulnerable to obesity, substance misuse, and mental health issues. So providing programming to support them is necessary. Now back to our geographic way of looking at this and the theme of healthy individuals in sick populations rather. In order to move the needle on population health, we're going to have required focus on the counties in dark blue, that is circled in red. And remember, there's a substantial difference in life expectancy between these red and green counties, from up to 8 or 9 years difference from top to bottom. But we need to do this for a sustained period of time. So you'll notice in the image, I'm suggesting the upper right are the 3 strategic plan foci. So a health in all policies approach driven by data, a cross-sector collaboration, and then increasing the workforce and leadership capacity with regard to population health in such a way that these red circled counties would experience particular programming and focus to elderly populations, youth, and tribal communities. This will mean focusing on those high priority areas: tobacco, alcohol, and other issues, obesity, fresh fruits and vegetables, physical activity, in order to prevent hypertension, diabetes, cardiovascular disease, and kidney disease, with poverty reduction through minimum wage laws, workforce protections, disability, and other unemployment benefits, in order to, at the population level, to reduce those high burden of disease conditions that were introduced previously. So imagine for a moment, how might we think about this whole state as our home? And ask the question, if some communities are struggling, then we're all sharing in that. We all have family members who live in various places around our state. And how might we find each community contributing in the ways they're able to support other communities across our state by sharing of resources, sharing of expertise, sharing of best practices in order to see the whole state benefit. Now let's come back to a summary slide of the whole presentation. So we have the three-pronged strategic plan, health and all policies driven by data, increase workforce and leadership capacity in population health expertise, with cross-sector collaboration of all sectors that involve health in our state, from hospitals, clinics, nursing homes, pharmacies, to local public health, to the Department of Human Services, to our schools, our faith communities, our law enforcement influence. And this is the strategic plan, which would then provide focused attention on the 5 high priority focus areas of obesity, substance misuse, mental health, poverty reduction, and healthcare system redesign. In order to reduce the burden of disease as a result of these top heavy hitters, ischemic heart disease, lung cancer, COPD, diabetes, low back pain, and opioid use disorder. And the image is meant to show that they're going to be going down in incidence and prevalence. And then we do this in a sustained manner for at least 20 years. It took us 33 years to fall from the first healthiest state in the nation to the 19th healthiest state in the nation. But I'm betting on we North Dakotans that we can get back to #1 in 20 years and see our population health increase year by year with focused attention on these areas that we all know now, based on the evidence, are really the critical ways in which to improve population health for all. I'm betting on North Dakota to focus its attention in this way. And here I'm basically proposing a model to answer the question, many of us feel healthy as individuals, but then why do we have these burdens as a state in our populations? And I'd like to see that we have healthy individuals living their best life in healthy populations, supporting each other in an equitable way in order to see the whole state benefit. I now have time for some questions. If anybody has any questions or comments, this is really meant more as a conversation starter than anything else. So I welcome any questions or feedback that anyone might have at this time.
Thank you, Dr. Strand, for such an incredible presentation. I do believe we have one question so far in the chat. So someone said, very interesting and useful presentation. Let's see here. This is a very long one. I particularly like the realistic look at what clinic health services can accomplish and the addition of poverty as an important element in population health. What I didn't hear in your discussion was the influence of an inequality as a factor that affects virtually all the other indicators of health or lack of it. Dr. Stern, you want to speak to that?
Yeah, definitely. I appreciate that. Like I said, this is, meant to be an invitation to a conversation. And thank you, Marianne, for that, that addition. I think it's pretty easy to see when you look at the 5 lowest life expectancy counties in our state being overlaid with our 5 tribal communities. You'll notice, that to me speaks of horrific inequalities, both historic and presently. So no question about it. Those are, issues that need to be addressed. So thank you for bringing that, to our attention. Teresa, do you have a question or a comment?
I do. Just a comment. We've been doing a lot of work on Alzheimer's prevention in Barnes County. And I noticed that none of the risk factors on that diagram that you had pointed to Alzheimer's. One of the primary things that the Alzheimer's Association is wanting public health to do is to make the connection between brain health and heart health. And just thought it was interesting.
No, thank you for bringing that up. It is, I confess, I am less familiar with some of the key upstream contributors to Alzheimer's and dementia. So that's a great, great contribution. I appreciate that. Yeah. And obviously I didn't, by not including anything, it wasn't meant to be excluded. It was more a matter of trying to go with what had the best, evidence. So, but that's certainly an issue. And wouldn't you also assume that it's, basic mental health and, physical activity and healthy social lives for a long period of time would also potentially delay or prevent dementia, would it not?
Absolutely. Yes, the physical activity, the individuals who are more prone to Alzheimer's have other chronic diseases. So that's definitely a risk factor. And I like the fact that you included our aging population as an equity issue. We've been working in that area, trying to use some of our health equity funding to address Alzheimer's.
Mm-hmm. For those who don't know, Teresa is administrator at City and County Public Health in Barnes County and Valley City. Thank you, Teresa. What would you all do? I entertain any questions you have, but we have time here. I'd love to hear from others. I see the names on the screen. I know many of you have a lot of expertise and experience in this area. Please, unmute yourself and share your reaction or your comment. I hope we're starting a conversation that can start to transform our understanding across our state.
I have a question, Dr. Strand. I was going to ask, how do you think the COVID pandemic impacted maybe the life expectancy? And do you think we'll maybe see a change in that with, vaccination and some of the other things that we're seeing? Do you think we'll see an increase again, or do you think it'll continue to trend down for life expectancy?
Yeah, excellent point. There's no question that the COVID pandemic reduced life expectancy. However, the trend had started back in 2010 with these what were called deaths of despair. And so the criteria that I described, the mental health issues, substance misuse issues, occupational hazards, chronic pain, depression, that was a cluster that resulted in significant reduction in life expectancy among middle-aged working populations. So yeah, no question, COVID exacerbated that, but it was actually just an exacerbation of an already existing trend. So no question, now that we're through the pandemic and have a lot of tools to prevent those deaths due to COVID, I believe that we'll see some rebound there, or at least a leveling out. But I'm still persuaded that all those other factors are the most significant. A pandemic, as horrific as it has been, it's still an acute issue. Now, acute for 2 years, that's really acute. I'll grant you that. But in the long sweep of things, generationally, it is an acute issue. And all the issues that I spoke to are all chronic issues that operate on a decade or generational level. And I think are primarily responsible for things like life expectancy and quality of life. So thank you, Lauren. Good comment and good observation. Yeah. Chelsea, could you please unmute and just make your comment for us? We'd love to hear from you.
Hi, Dr. Strand. I just put it in the chat. I think, there could always be better collaboration and communication among agencies around North Dakota. And also the risk factors and correlations that you talk about between the risk factors and the diseases, I think there could be better statewide media campaign around prevention and these risk factors as a whole to the public to better present our messages.
Chelsea works in alcohol, tobacco, and other drugs work in Williston up in Northwest North Dakota. Thank you, Chelsea.
I just had another thought, or question, I guess, and maybe it's not even relevant, but when you showed the map with the quartiles and the circled areas of most concern, the colors of the tribal areas were the same as Stutsman County, which is right next door to us. So I was curious if you felt there was a reason for that. I mean, I can dig into that myself, but wondered if you were aware of what that might mean.
Yeah, good observation. So there's two dark blue counties that are out of, the red circled areas. So this is now not the lowest 5 and highest 5 counties. This is now by quartiles. So obviously the line for the lowest life expectancy starts to move up significantly. So, I'd have to, so in other words, these two counties could still be in the lowest quartile, but actually because the lowest 5 counties are so low, you're going to have counties that make it in the lowest quartile just because you have to divide them into groups of 4. You're going to have counties that are in the upper part of the lowest quartile, but who are darn close actually to the average life expectancy. So I'll follow up on that to confirm, but that may be a little misleading. I probably should have kept this slide just focusing on the 5 upper and 5 lower. So sorry for switching my units on that, Teresa, and a good observation. I'll follow up with you on that.
Thank you.
Did you find the geographic explanation helpful? I think public health, it's about populations, it's about risk factors, it's about policy, it's about geography. So I tried to pull that together today.
Will we have access to the recording? I saw it was being recorded.
Yes, a recording of this will be on the College of Health and Human Sciences YouTube page. I also will be sending out, hopefully, to everyone that registered for the event, I'll send the YouTube link out as well.
Perfect. I would like to share it with our staff here.
Hi, Carissa.
Hi, Dr. Strand. Nice presentation. I was trying to get all my thoughts together because I have multiple thoughts, and I was trying to be succinct with my thoughts and so I don't ramble. But it was very evident that the reservation lines, like the counties they were in, were substantially lower in like health disparities compared to like other counties. And so I was looking at the high priority focus areas we were talking about, like substance misuse and mental health. And I know that learning your language and your tribal culture are substantial protective factors and help alleviate mental health issues as well as substance misuse. So I think finding ways to support that programming on and off reservations would be key. Also, since I've been living in North Dakota, I've faced a decent amount of racism and ignorance. So I think building awareness across the state of, like you were mentioning, the systemic issues that brought us to where we are today, like educating those who aren't Indigenous about why the situation is the way it is would promote funding allocations to those communities, because sometimes we meet sort of pushback, like, well, what about us? And it's like, well, you got to see the data and see the situation that we're in and why we're here in the first place. So I think the first step would be building awareness so more people are aware of the issues.
Carissa, thank you for those comments. I confess I'm never quite sure how to depict these issues, and I've decided, to take that risk because I'm so conscientious to not in any way imply that these 5 lower life expectancy counties are somehow to be stigmatized or blamed for that finding. And so I hope I've done justice or fairness to depict that it's not their choice or fault. It's a function of 250 years of aggression and then recent decades of inequality. So appreciate your comments to enrich that, because I don't feel I can speak for tribal communities, but I also cannot keep from speaking on behalf of tribal communities. So thanks for enriching that understanding. Appreciate it.
Do we have any more comments or questions? Dr. Strand, any other dialogue we want to discuss as a group before we leave for the day?
No, the interest in the topic is evident by all y'all being here. So thank you. And we'll all just pick up from here and each do our part to try and help our communities, our populations, our neighbors live their healthiest and best life. So thank you for your attendance today, and appreciate and welcome any further conversation moving forward.
Thanks, guys. I also want to say that I put information on future sessions in the chat. You can register today. We will be having a session on November 3rd, which we will be hearing from the American Indian Public Health Resource Center and learning more about what they do in our region. And on December 19th, we will be hearing from Amelia Nichols and Maeve Williams discussing their work at the Center for Immunization Research and Education. Please register for our future webinars, and we really appreciate your time and your discussion. And thank you for attending our October session for the Department of Public Health. So I really appreciate all your time. And again, I will be sending out a recording of this session to our attendees as well.